Good morning, everyone. Today I will discuss with you an interesting drug called as Cabergoline. Cabergoline is a synthetic ergoline derivative which is centrally acting, mainly acts on anterior pituitary and corpus striatum. It is a full agonist at D2 receptors, 5-HT1B receptors and 5-HT2B receptors. It also shows partial agonistic activity at D2L receptors, D3 receptors, D4 receptors, 5-HT1A, 1D and 2A receptors and also 5-HT2C receptors. It is also considered as an antagonist at alpha 1A, 2A, 2B and 2C receptors. But the antagonism is not manifest because no efficacy or intrinsic activity is shown. Now, the class with which it belongs is ergoline group, and bromocriptine and pergolides are the other drugs. Now, compared to bromocriptine and pergolide, the drug has highest D2 selectivity on the pituitary lectotropes which secrete the prolactin, and it also thus inhibits prolactin secretion because it acts as an antagonist. It suppresses the secretory activity. Compared to bromocriptine, it is more potent, has highest affinity for D2 receptors and is considerably long-acting. Unique properties make the actions which can be explained. The dopamine is considered as PIF, that is prolactin inhibiting factor, and it is a primary regulator of prolactin secretion from pituitary lectotropes. Dopamine is released from hypothalamus into the hypophyseal portal blood supply through tuberoinfundibulum and reaches the pituitary lectotrope in anterior pituitary and acts as an agonist on the D2 receptors and thereby inhibits prolactin secretion. Now, in other pathways, particularly dopaminergic pathways in the nigrostriatal system, the postsynaptic D2 receptor stimulation controls the abnormal movements, whereas presynaptic D2 stimulation has a neuroprotective effect. Therefore, by these two effects, the cabergoline is also effective in Parkinsonism. Among the other effects which are important and notable, that there is reduction in ACTH secretion, particularly from ectopic sites and also from adrenal cortical tumors. Now, these have expressed D2 receptors. Therefore, it has been tried in Cushing disease with or without pituitary adenoma. The cabergoline also modulates neurotransmitter activity in the striatum as explained earlier. Therefore, it benefits the patient with Parkinsonism. It also has hallucinogenic effects because of D2 agonism, that is due to 5-HT2A receptor stimulation. Now, if you look at the pharmacokinetics, the drug is given orally with a bioavailability of about 60% maximum, and it undergoes rapid first-pass metabolism, and the metabolites are less active. Half-life is very long. This is very unusual, about 65 hours, even with low doses as used in Parkinsonism, and maybe as long as 100 hours or more when higher doses are used in prolactinoma. Therefore, it shows saturation kinetics. Now, peak plasma levels are around 30 to 70 picogram, and peak plasma time is 2 to 3 hours. T max is 2 to 3 hours. About 40 to 40% drug is protein bound, and its metabolism is extensive in the liver by hydrolysis, and there is a mixed excretion, urine 22% and fecal 60%. Renal clearance is less than 1 liter per minute. Usual doses of cabergoline, the tablet is available as 0.25 milligram and 0.5 milligram, and in some countries cabergoline vaginal contains 0.5 milligram. It is used in females who cannot tolerate the tablet because of nausea. Now the doses vary from disease to disease. In hyperprolactinemia and adenoma, therapy is initiated with the smaller doses of 0.25 milligram twice a week or 0.5 milligram once a week. The dose is gradually increased and reached 2 milligram 2 to 3 times a week as tolerated. The dose is increased only once in 4 weeks, and doses 2 milligram per week or less usually normalize prolactin levels in 80% of patients with high prolactin level initially, and it also induces remission in significant number of patients with prolactin secreting. Now, among the therapeutic uses, as will be clear, cabergoline has wide therapeutic efficacy in a number of disorders. They include suppression of lactation, hyperprolactinemia with adenoma, as an adjunct to prolactinoma, as an adjunct to surgery or radiotherapy in acromegaly, in Parkinsonism as monotherapy in early disease or add-on drug with co-levodopa in anovulatory cycles and PCOD, non-pubertal mastitis, uterine fibroids, end of the term pregnancy with heart failure, because increased prolactin is responsible for heart failure, but this is an investigational use. And among the off-label uses are adjunct to SSRI to counter the decreased libido in patients with endogenous depression, and recreational use to increase the sexual drive. These points will be discussed. Now, as far as suppression of lactation is concerned, cabergoline inhibits prolactin secretion, thereby reduces formation of the milk when breast engorgement occurs and mother cannot breastfeed. Now, this can occur after parturition if there is a contraindication to breastfeeding, or because there is a stillbirth or late-term abortion and milk suppression has to be done. A dose as low as 1 milligram total on the first day of parturition can suppress, but this dose may cause nausea. Therefore, 0.25 to 0.5 milligram can be given. 0.5 milligram as 2 doses, or 0.25 milligram every 12 hours for 4 doses. This regime is better tolerated. Now, even this, because after parturition, BP may return back to normal, so one has to watch for nausea and hypertension. In the treatment of pituitary adenomata, drug shrinks pituitary prolactin tumors, lowers circulating PL levels, and restores ovulation about 70% of females with microadenoma and 30% females with macroadenoma. The pressure symptoms, particularly visual due to optic chiasma compression, reduce, and pregnancy may occur within 1 year. The dose starting is again slow, 0.25 milligram twice weekly orally or vaginally, and dose is increased gradually according to serum prolactin levels to a maximum of 1 milligram twice weekly. When this therapy is stopped after a continuation of 1 to 2 years, then hyperprolactinemia may recur. It recurs variably from 68 to 84%. Another indication is acromegaly. Cabergoline is most effective in tumors which secrete both prolactin and gonadotropin hormone, but is also effective in patients normal serum prolactin levels are shown. Now, this is given when IGF-1 levels are between 1 to 2.5 times normal. Now, cabergoline can shrink about 1/3 of the tumors in more than 50% of cases, and is considered to be safe during pregnancy, although it is best to avoid it if alternatives are available. Initial dose is 0.25 milligram orally twice weekly, gradually increased to a maximum 1 milligram 3 times weekly. This is important, and the dose must be monitored by estimation of growth hormone and IGF-1. Treatment of Parkinsonism usually requires levodopa with carbidopa. This co-levodopa combination can produce unacceptable side effects if dose titration is inadequately done. It is found that cabergoline improves motor symptoms, reduces severity and duration of wearing off effect, and diminishes need for levodopa. It is also useful to normalize sleep disturbances in Parkinsonism and can be used alone in a mild case or as a second-line drug along with co-levodopa to reduce levodopa dose and reduce on-off phenomena. Dyskinesia are not much worsened when carbidopa is used, and it is this condition where very low dose is given, 1 milligram per day. It is given daily, unlike other diseases where it is given weekly, twice or once weekly. Average daily dose is 2.5 milligram. Compared to bromocriptine, cabergoline has greater efficacy and tolerability than bromocriptine. In male sexual disorders characterized by orgasmic disorders or erectile dysfunction, which may be usually psychogenic, drug has been found to reduce high prolactin if it is high initially and improve sexual desire, libido, and erectile dysfunction disappears. Another recreational sexual use is that it has been found that cabergoline reduces refractory period and allows to experience multiple orgasms in rapid succession. So if somebody wants to do sex repeatedly, probably this is a drug for that purpose. Although this could lead to abuse. Now the dose is 0.5 milligram twice a week for this. Potential emerging roles of cabergoline are chronic pain in endometriosis, treatment of migrainous headaches, assisted reproduction, PCOD, polycystic ovarian disorder, resistant depression, and ACTH secreting pituitary. Now, the unwanted adverse effects in usual doses are nausea, vomiting, dyspepsia, dizziness. Blood pressure should be monitored because hypotension can occur. Sometimes there is edema feet, sleep disturbance, vertigo, abnormal movements and hallucinations can occur. We have already explained because of D2 agonism. Palpitation, angina, but the more sinister and problematic adverse effects are long-term pleural pericardial fibrosis, and a causal relationship has been found with high cumulative doses of cabergoline and valvuloplasty. And it also inhibits synthesis of TSH. Therefore, if patient has hypothyroidism, their TSH has to be monitored very. It is best to avoid in uncontrolled hypertension if there is allergy or unacceptable adverse effects with ergot derivatives, severe hepatic disease, particularly when there is hepatic steatosis, it is contraindicated, concurrent use of D2 antagonists, and history of pulmonary, pericardial, retroperitoneal fibrotic disorders. Women planning pregnancy is best to avoid to use. So the summary points are: cabergoline is a versatile drug which is a long-acting D2 antagonist in brain and mainly acts on pituitary, lactotropes and nigrostriatal neurons. The ergoline derivative has been proven to be efficacious in hyperprolactinemia due to pituitary adenoma. It is also useful adjunct in Parkinsonism and is very useful for suppression of lactation if it is to be suppressed because of medical reasons, and it has potential for other indications such as male sexual disorder and treatment of migraine headache. So thank you very much.